and after biventricular stimulation, they are in synchrony. Now, the synchronization therapy is one example where this parametric display is being used. Soon we will see on our three-dimensional data sets encoding on the endocardial surface imaging the delays of contraction, so that we online can take our decisions during interventions. Fusion imaging with higher dimensional imaging. This is a catheter ablation tip. This is echo, and then we have here the mapping of the activation, and we put them together in a fusion imaging, and that's being done more and more. System miniaturization. What we have seen, we have moved from laboratory systems weighing. Yeah, I will be the last speaker. And this is a slide modified from Jim Seward. And we went down and down and down, and now we have the P10, which is an instrument which is a pocket size. That's the one. So we have seen now very powerful systems that have all the functions because of this computer miniaturization. This is the P10 that is commercially available. It's pocket size, and it's coming very close to the ultrasound stethoscope. This is a real stethoscope because stethos means chest and scopain means seeing in the chest, whereas the stethoscope that we are using and have in our pocket is a stetophone. You can only hear with it. You cannot never have a see with it. So that's a misnomer. Now the image quality of these devices is quite good, and just for rapid decision making at the bedside and orientation, it's very useful. There are other prototypes that are being worked on. This was a prototype for Siemens, where you just look in this viewer and see an enlarged image through a magnifying glass. So this is already coming very close to a stethoscope. Special dedicated systems, to me, is the future. The surgeons don't need all the whistles and bells that you have on these big machines. The big machine is in their way. The only thing that they want is to see whether their repair is perfect. They need a good image. And they are not going to bother people with strain rate. All these things are not needed in certain environments. Also in the interventional laboratories, there is a lot of functions you don't need. And you can do that with specially dedicated. The aorta scan is an interesting recent development. That's for the general practitioner, because in the 65 plus, 7% of our population has a dilated aorta. And once it's over 5, it's an indication. It's very dangerous to have this time bomb in your abdomen. So that's an indication for surgery. And the general practitioner should do that. We also, as cardiologists, when we have a patient with coronary artery disease with atherosclerosis, means that we should check in all our patients over the age of 60, 65, the abdominal aorta. It takes just half a minute in experienced hands to take the dimensions. But this is an interesting device that does a lot of the interactive work so that you have the right dimensions. So the miniaturized device will revolutionize the physical examination because they will complement it anytime, anywhere at the point of care. There is a rapid diagnosis of critical conditions, or at least an orientation to refer the patient. Then there are focused clinical questions and follow-up that we can apply. We can use it for screening, but that's already more expert work, and a teleconsultation. And it's my opinion that echocardiography should become available to all general practitioners and all healthcare professionals. General practitioners, they can look at the liver, metastasis, abscesses, cysts, jaundice, hepatic or extrahepatic abnormalities are readily detected. The gallbladder, the kidney, hydronephrosis, urine retention. We can look at the hepatic vein in heart failure, for instance. Polyvascular disease, the abdominal aorta, an enlargement of the heart effusion and calcific valve. These are straightforward diagnoses, and a general practitioner, everybody can do that, and it's something that is done in office practice and with proper referral of the patient. If a general practitioner cannot learn to scan the abdominal aorta or to see whether a heart is dilated or not, and there are so many asymptomatic patients with an enlarged heart or mildly dilated heart that are still asymptomatic, that are out there, and the general practitioner, like measuring the blood pressure, could do that. Remember that in the 20s, my father-in-law, he measured blood pressure, and this was something really, really fancy in those days. And it was only the doctor who could measure the blood pressure. And then after the World War, you know, everybody started doing it and more, and so, and now you can buy a blood pressure manometer on the airport, and most of the people have one at home. So the reason or the way to implement that in general practice is to teach ultrasound at the university. It should become part of our curriculum. Connectivity is another problem in the hospital. In some hospitals we have already wireless connectivity, and all the different areas where echo is useful, like in the baby intensive care unit, the lab, the surgical theater, that can all be interconnected so that you can work with a few experts. I think that's how it works in the Mayo Clinic. That's a setup that we have. We have a two-way audio with the surgical theater. We have a camera, and we can communicate with the surgeon, and we don't have to go down and to dress up, because the surgeons ask you to come down at 10 o'clock or 11 o'clock, and then they are done at 12 o'clock. You lose too much time there. That's how we use it. A major advantage for these smaller but powerful ultrasound systems is that you can have them powered with a sun panel. So that's available all over the world. The only thing that you have to carry with your machine is a sun panel. But when you travel, I was last year in Siberia, and everything is done there with portables, and they use the sun panels. And so they power their machine. So that can be done in Central Africa and so on. And we should not think that echocardiography is real-time strain rate imaging. Most of the people don't care about that. That's research. And of course, sometimes we get, of course, in our management an answer which helps. But the practice for and certainly for the third world, is just a simple machine where you can look at a heart, dilated or not, effusion or not, cardiomyopathy, valvular disease, and congenital abnormalities. That's what we need. And the same machine can be used for deliveries, for pregnancy, for major pathologies. That's what you need there, not CTs like they are installing in some of the countries. I have trained people from Tanzania, and they go down to Mwanza, and then they get from UNESCO a machine, a General Electric machine, and he writes me back that they do not have enough power to power the machine. And most of the day, you know, the power is out, and they need it for the intensive care unit, and that's the reality. And there they need echocardiography, and that's where the big future is, not MR. Now the appropriateness, what you see here is the United States statistics 2000 to 2004 and 2004 to 2005, and you see that the applications for CT are little going down. Nuclear imaging is seriously going down, and echo remains about the same. But the problem is that there is an annual growth of 8 to 10%. And what we need is evidence-based cost effectiveness of our imaging techniques. And that applies also for echocardiography. And therefore, there is now attention to this appropriateness. And in the JACC journal and in JACC cardiovascular imaging over the last couple of years, there were a couple of articles that are very interesting to read on the appropriateness of tests and the economics of imaging. Because in the future, if it increases at the annual rate as it increases now, healthcare cannot afford that anymore. So that was a rapid overview on what I think what is important for the future and what the directions are where we will see the newer developments, and I thank you for your attention.